All right. Um, there are a lot of themes that Jean-Fred introduced that are going to be consistent amongst many of us who are trying to push the field. And I think Jean-Fred's comments were really quite appropriate because we are pushing, but unfortunately we're going into headwinds, and those headwinds become the practicalities. The practicalities of getting appropriate doses, the practicalities of doing therapeutic monitoring, the practicalities of doing clinical monitoring, not having a point of care calprotectin, so it takes a week to get back our results from these. So we have many headwinds to get where we think we can go. And eventually, you know, I think back to Martin Luther King, who had a dream. I'm going to pass on Dan Present's dream of treating these diseases without corticosteroids, because I think we have the opportunity to do that, but unfortunately those headwinds are pushing prednisone against us right now. So be patient, David says. Can we have the next slide, please? Because these are not moving. So Jean-Fred introduced this concept of treat to target, and we're going to continue to discuss this along the way, including therapeutic drug monitoring later today. But as we just alluded to, there are a number of different targets. There are drug targets, there are therapeutic drug targets, there are clinical targets. The clinical targets have different levels. And you need to be very cautious when you're looking at all these slides of results of response, which is always going to be high, remission, which is going to be lower, steroid-free remission that's going to be even lower, biologic remission that's including endoscopic and clinical as well in absence of biomarkers. And then David introduced the term for ulcerative colitis, a histobiologic or histoendoscopic remission that's going to be even more challenging in Crohn's disease. Now, just as our colleagues in rheumatology have learned, we can actually prevent joint space narrowing and destruction in the setting of rheumatoid arthritis if our effective drugs are introduced early into the course of the disease. And we can probably do this, and I'll get back to this a little bit later, if we introduce, as Jean-Fred has said, earlier in Crohn's disease. The problem we have right now, and it's the same in rheumatoid arthritis, once a patient has joint deformities, you can't get the joints back together. So we have to have secondary goals along these lines, which is improvement in everything else besides the structural damage. And that's one of the issues that we have in IBD, particularly in Crohn's disease, because we are already starting therapies when patients have structural damage in the most part. They have disease duration of 10 to 12 years in the clinical trials, and they already have subtle findings of either non-obstructive strictures or perianal fistula or other complications that we're trying to prevent when we're actually starting therapy. And one of our impediments is how do we assess these patients who are not going to heal their mucosa but are going to have clinical improvement with the therapies that we're administering. So David's introduced the TNF inhibitors. We actually have one extra that is approved in Crohn's disease. That's certolizumab pegol, whereas golimumab is approved for ulcerative colitis, but not in the setting of Crohn's disease, although they're all extremely similar. And I would even add in etanercept, which we are not using, and it's basically a dose-related issue with etanercept. But nevertheless, we've learned a lot from these different drugs in the treatment of IBD. So what have we learned? We've learned that these therapies are effective for the treatment of both Crohn's and UC. They are all immunogenic, more or less. And I like to point out, you can make the same drug more or less immunogenic. If you give a little dose of infliximab, 1 milligram per kilogram, 60 or 70% of people will develop antibodies. If you give high-dose induction and continuous maintenance, you drive the immunogenicity down to 13%. And if you give high-dose induction, continuous maintenance, and add an immunomodulator, you bring it down to 6%. Same drug, different immunogenicity based on the context of that. We've also learned both in Crohn's and UC, as David mentioned, that combination therapy is more efficacious than monotherapy, and we're trying to determine who really needs that combination, that boost of a 13% boost or such. And then we're learning to understand the different mechanisms of either primary failure or secondary failure with these drugs. And we also have to clarify the baggage that comes with TNF therapy, which includes other immunomodulators, including thiopurines, because much of the issue with lymphomas are probably related to the thiopurines rather than the TNF inhibitors. So I think it's pretty obvious now that we've learned that combination therapy is better. The route to getting there was a bit complicated because patients put into the early trials of TNF inhibitors had already failed immunomodulators. Many of them had. And when we look back, we did not see any differences in those patients, whether they were on combination or monotherapy. So these were patients who had already failed. And of course, when we go back and do it prospectively now, and I emphasize to the fellows all the time and our trainees, there is a huge difference between post hoc or retrospective studies and doing things prospectively. And just as an example, that David mentioned with 5-ASA in ulcerative colitis on top of a biologic therapy, that's a post hoc analysis. And it remains to be determined, as he mentioned, new patients, combo versus monotherapy. And we have to learn that with each of these. But nevertheless, there's about a 13% benefit of combination therapy in bio and immuno-naive patients in the setting of Crohn's disease. We have begun to look at that. This was also mucosal healing in the setting of Crohn's. But Jean-Fred and I looked at whether or not this was due to synergy between the immunosuppressive and the biologic, or was it just the biologic pushing up drug levels? And based on this quartile analysis, looking at people who had different quartiles of drug levels, you would expect that if there's synergy in each group, there would be a better outcome with at the same drug level. And that's not what we found. What we found post hoc is that the patients who had the drug levels were the ones, the drug level was driving the response, not synergy between the agents. And again, this is a post hoc analysis, would need to be proven going forward to treating patients prospectively to drug levels. And that remained a challenge. So Jean-Fred already demonstrated this slide and pointed out the window of opportunity of treatment. And actually, in his view, that window is moved even backwards to pre-symptomatic inflammatory bowel disease with some of the serologic studies that are going on. But I would point out that early on is going to be our best opportunity to change the course of the disease. And again, those headwinds have pushed us back to where we're least effective in our treatment, as I will show you. So this is another version of the same slide demonstrating the progression of Crohn's disease towards transmural complications. So it brings out two different factors. The first is, what is the prognosis? Well, we know that some of the patients have a rapid progression to transmural complications, and we've begun to identify some of those risk factors for bad prognosis compared to the patients who have more mild Crohn's disease, perhaps the aphthous ileitis or an aphthous colitis, who aren't going to progress to the transmural complications. So that's prognosis. The other is how much bowel damage there already is. And we know that if we treat patients early, just as in RA, we can have the potential to prevent bowel damage if we're using the drugs in the right way at the right time. But this is where we've been using the drugs. After the patients have had multiple years and failed multiple therapies, and this is the least effective place to put our therapy. Hence, 50% of patients who are started on a TNF inhibitor in the United States are off within the first year. it means we're doing two things wrong, at least, in my opinion. We're using them too late in the course, and we're not doing adequate therapeutic monitoring to be continued later. We actually have evidence in clinical trials regarding these 2 points. The first is timing. If you look at the results, and these are the remission rates across clinical trials based on the average duration of disease when patients entered the trials. You can see that the response rates early on are close to 80% versus 40% in the patients who have had the drugs introduced later in the disease. Similarly, the Canadian group has looked at whether or not you start patients based on their Montreal classification of inflammatory disease, which is the B1, versus stricturing or fistulizing disease, B2s and B3s. And this is the progression to surgery. The patients who are treated early on before structural damage have a better long-term prognosis than the patients who are treated once they already have damage. And this applies also to Ustekinumab. These are patients who had treated in an open-label study in several centers in Canada. Again, the patients who have purely inflammatory disease without strictures or fistula have a better persistence of therapy than the patients who have more transmural disease. The same has been seen in open-label experience with vedolizumab in what's known as the Victory Consortium. It's patients who had more severe disease at baseline, who had the factors, transmural factors such as perianal disease. The smokers do not do as well as the naive patients who are treated early on, and that actually includes not only clinical responses, but endoscopic healing is better in the patients with earlier disease than late disease. And one of my themes is going to be that particularly in Crohn's disease, once you have deep ulcers, you got a snowball's chance in heck of getting those ulcers healed. And so we are all seeing patients now, and I'll show you a bit more data on that, who are referred to us. The patient's feeling well, but they still have ulcers with Crohn's disease, and the doctor or the patients are asking, should we escalate therapy? Well, I think that that's usually going to be pretty futile to just achieve that mucosal damage, particularly with the deep ulcers in the setting of Crohn's disease. Now, as far as newer therapies, Ustekinumab in Crohn's disease has been the most recently approved therapy, and it's going to open the door to other inhibitors of interleukin 23 that are under development, and you can see some of them outside in the pharmaceutical display area outside the room. Ustekinumab, I think you're all familiar with. It's been available for the past several years. There have been comparative questions, just as there were between vedolizumab and adalimumab, and we do not yet have good comparative trials of Ustekinumab versus TNF inhibitors, although there is currently a trial underway looking at Ustekinumab versus adalimumab in the setting of Crohn's disease, but we do not have that data as yet. The response and the remission rates look pretty similar. These are not head-to-head trials, but they look pretty similar to what we've seen with the TNF inhibitors. One of the advantages of Ustekinumab, actually there are two, I would say, good properties. Number one, it is less immunogenic than many of the TNF inhibitors, and hence and number two, it actually appears to be safer. Despite the cytokine inhibition, we are not seeing the same kind of signal of infections and in particular pneumonias as we would see with the TNF inhibitors. Nevertheless, and I think I very much agree with David, In our programs now, we are approaching anyone who's going into an advanced therapy, such as any of the biologics or tofacitinib. We're looking at them in the same way, updating their vaccinations, as Gil Melmed will be talking about later, and preparing them for these advanced therapies. It's just too hard to say, oh, this patient's going on Ustekinumab, we're going to do one thing, and tofacitinib another, because many of the patients are switching back and forth. So I'm sure that Gil will preface that. Now, what we've also demonstrated, in the same way that we looked at with tofacitinib, going back into diaries of the patients who were in the clinical trials. These were not predefined endpoints, so this is, again, going back and it's post hoc data. We actually can show improvement within the first days and certainly within the first weeks of treatment with Ustekinumab in the setting of Crohn's disease. This refers to bowel movements, this refers to abdominal pain, and the general well-being starts to improve very quickly after the infusion. Now, this is not remission data at all. This is patients starting to improve, so we understand that. We've also recognized the persistence. With Ustekinumab therapy, it looks like there is a better prolonged response, perhaps, than the TNF inhibitors, whether this is due to immunogenicity or its pharmacokinetics and a longer half-life, or its mechanism or patient populations remains to be determined. But the majority of patients who respond to Ustekinumab maintain their response now at least out to 3 years. And that includes patients who were TNF naive and TNF exposed patients. Once they respond, they tend to continue to respond. But as we've seen consistently, if patients have lost response or not responded to one agent, they don't do as well on the second agent as if the patients who were naive and just introduced to that second agent. Jean-Fred already talked about how we're evolving therapy to this monitoring not only of drug levels, but also clinical responses with biomarkers such as C-reactive protein and calprotectin. And I'm not going to repeat that data. But I will talk a bit about the challenges in getting mucosal healing in the setting of Crohn's disease. We know that patients who have deep ulcers at presentation are the least likely to have a good response compared to patients who have shallower ulcers in this setting. And indeed, Bill Sanborn in California has, outside of clinical trials in his clinical practice, push doses in order to achieve clinical and endoscopic remissions. But even in his hands, in the best of hands of the clinicians who are very aggressive, less than 60% of the patients with Crohn's disease achieved endoscopic healing in that setting. It remains a challenge, and we need to continue to determine how we're going to monitor these patients in that absence. And even with our newest drug, with Ustekinumab, less than 20% of the patients had endoscopic healing in this prospective clinical trial. So it remains quite a challenge. Hence, I go back to this very important study and think, where can we really impact therapy in the setting of Crohn's disease? Well, we've talked about that early disease, but I also think that there's a secondary setting, and that is post-surgical. If we take out the burden of disease and start anew in some of these refractory patients, there I think we have a better opportunity of actually recapturing a long-term response versus going on to the the third, the fourth biologic or complex therapy. They're going to be futile in those patients. Take out the disease, start anew, monitor postoperatively. And where are we treating patients? Way too late. The horses are already out of the barn by the time we're treating them. So, how are we going to go about this? We need to treat earlier in the course. We need to ensure a complete response. Consider combination therapy. We're going to learn more today about pharmacokinetics and dynamics and how to utilize therapeutic drug monitoring in these patients. So what is this implication for practice? The patient selection is going to be critical to maximize the effectiveness and safety along the lines that we're going to continue to be discussing today. As far as new therapies, well, David pretty much emphasized them. They're going to be in your slide set. I'm not going to present phase 2 studies because they're not meaningful until they really come out into a translation, and we can certainly talk about them in our panel discussion. So I hope this gives you kind of an update as to where we're at, and I look forward to further discussions. Thank you, Dave.